Assalamu alaikum, everybody. Thank you for your time and your interest in this very important subject of the day. My name is Rashid Ahmed. I am Executive Director of UMMA, and this session is designed exactly to become a resource for these kind of needs. Like, somebody can perhaps go from one of the UMMA members, one of the clinics. We can coordinate these kind of needs. We can work together, develop a platform. That way we become the resource for it, because we can't do it. We are not running such a clinic on our own, but we can certainly bring together people and provide this kind of knowledge base. I also thank our panelists here, Dr. Yasser Aman, Dr. Altaf Qasruddin, and Dr. Taif Kaisi. Today, this session is designed for people who are interested in offering health care at low cost or no cost to underserved population. There are many different ways to serve the underserved population, entirely free or federally funded, or a network model, which three of these doctors are actually practicing a different model. They will go over each of their model, and they will explain, and you will have an opportunity to understand. And if you have any follow-up questions, we will also cover that. Dr. Yasser Aman here has to leave for a flight. Dr. Yasser is currently serves as the President and CEO of University Muslim Medical Association, community clinic, UMMA. This is the first clinic which is started by Muslims, Muslim physicians at that time, perhaps Muslim students at the end of their medical school in Los Angeles area. Dr. Yasser Aman will cover the model that is federally funded, federally qualified. That means it qualifies some funding from the federal, which again he will go over. So I invite Dr. Yasser Aman to come and go over.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم صل على سيدنا وحبيبنا محمد صلى الله عليه وسلم السلام عليكم ورحمة الله. I wanted to just thank on behalf of the UMMA Clinic for Imana inviting us to this opportunity to, I guess, immortalize this presentation through actually doing presentation for people here, as well as recording it for a future, inshallah. So we ask Allah to benefit, us to benefit, as well as anyone who sees this, inshallah. I was tasked to kind of talk about the Ummah from the federally qualified perspective, but alhamdulillah, Ummah actually experienced both being a free clinic, a community clinic, as well as a federally qualified health center. But this is not going to be just an Ummah presentation, because I want to get really into the technical pieces around becoming a federally qualified health center, but I wanted to at least tell our FQHC story through our history. And so I would just, today I'm just going to go through the FQHC story, as well as what is the difference between the FQHC as well as the FQHC lookalike, as well, and then also the potential impact that health reform has with the FQHC program, inshallah. So Ummah, our mission, from the beginning, University Muslim Medical Association was started by a group of Muslim medical students that actually wanted to just respond immediately to the 1992 riots that happened, that caught the attention of the world, as well as specifically in South Los Angeles. And so there was a group of energized Muslim students that didn't want to just contribute to the cog of the medical machine, if you will, but they actually wanted to actually do something, and so they started up with a idea of being a mobile clinic, of having a mobile clinic. But interestingly enough, which is a theme that will resonate throughout my presentation, which is the core and essence of what federally qualified or community clinics are all about. The community said, we're sick and tired of mobile things. And because of that, because they were sick and tired of money coming in, And when money comes in to rebuild LA and so forth, and as soon as that money recedes, so does the help. And so, mashallah, the founders at the time actually took it upon themselves to take a mobile idea and actually build an institution. So with the help of the UCLA School of Medicine, Charles University, and the city of Los Angeles, they actually identified this building called the Child Care Center Betty Boop. That's where we were in 1991, which was a condemned child care center, which was filled with asbestos, exposed wiring, roaches, and so forth. And so a lot of the local politicians actually caught a lot of heat for shutting down this particular service to the community, because a lot of single moms now didn't have a lot of place to go to drop off their kids. And so as soon as these wide-eyed Muslim students wanted to actually do something, they knew exactly, and they pointed to this building. And alhamdulillah, over the years, now this is the building that we have now that we recently renovated, thanks to, alhamdulillah, the recent ARA funds that came during the stimulus package. But and I'll be very brief with the history because I want to jump into more of the FQHC piece. But from 1996, when we actually opened our doors, to year 2000 was when we were called the UMMA Free Clinic. We were literally going to shut down in 2000 because the medical students at the time did not go through any business planning school or strategic planning and so forth. They fundamentally moved on to residency program, and they didn't necessarily have a plan after their initial grant. And so, alhamdulillah, in year 2000, we raised $384,000 in one night. And that was the first time we went to the Muslim community. But we realized that one night that an institution like UMMA cannot be sustained, especially providing a very, very expensive product like healthcare, to a consumer base that doesn't have money to pay for it. And so fundamentally, it was a shift in our mindset that if Muslims want to establish an institution, they have to do it from sustainability's perspective. And so they had to think of diversifying the revenue. And so that's when we started writing grants. And it was difficult to write grants because it's like trying to get your first job. You have to get your first grant to get your first grant, to have grants to get your first grant. So it was a challenge, alhamdulillah. And then we started to have the philosophical debate that I'm sure free clinics around the country have, is should we bill, should we not bill, what does it mean to bill, the level of infrastructure and complexity of the organization that it soon becomes once you start billing. But we decided through a lot of introspective conversations that UMMA could not be considered as a pet. A pet is something you kind of dress up, sweaters, and make you and I feel better and good about ourselves. But actually, we had to look at it as a child with an amana, and actually ability to see this small organization become something bigger. So we then applied. We then started the path of FQHC, or the Federally Qualified Health Center. And so this is just more of a snapshot of what we do now. Over 35,000 patients since we started. We do around 16,000 patient visits a year. Often a lot of people see it, maybe think that we serve mostly Muslims. Obviously we do not. In South Central Los Angeles, we effectively serve the community that reflects the community that's around us. So predominantly Latino, African American, and people who are monolingual, people well below the federal poverty level. So our next project, just to briefly, just like we thought it was unacceptable when the Los Angeles was in flames, that a city can burn its institution and businesses down, and UMMA was born out of that. When we found out that one of the largest high schools and the second largest school district in the United States had significant health disparities, we decided to join with the Los Angeles Unified School District to build a school-based health center, which is essentially going to be a community clinic, 5 exam rooms, 3 peer counseling rooms for behavioral health, and also this clinic will be fitted for dental. But what the interesting thing is, and there will be 2 entrances, one for the students and one for the actual community. And we're very excited about this because, one, the school district is paying for the building. Two, alhamdulillah, we're charged to actually obviously come up with the operational dollars, but to fundamentally serve a very, very vulnerable population, which almost every time I ask the principal, 46, 47 girls are pregnant, is that 5,000 students go to this particular school at Fremont High School. But nothing in the country has been done at this scale where we will be adjacent to an acre garden. Alhamdulillah, there's actually an acre open space anywhere in South Los Angeles is unheard of, but the fact that we're actually on campus, the clinic is where that big arrow is, and this particular garden will actually have orchards, places where you can actually rent community plots so people can grow their own fruits and vegetables. There will be a kind of a meandering park where we'll potentially, inshallah, do yoga classes, and a whole place where we potentially can do a farmer's market. And we will ultimately integrate what happens at this particular garden and clinic in the curriculum for the students, so we actually can kind of really get deep into exposure to health, medical, career choices, as well as agricultural choices. So alhamdulillah, this is set to open in January 2013, inshallah. So for FQHC purposes, why don't we just get started on the technical part. How many here are actually either involved with a current community clinic or a free clinic, or so is that more on the volunteer side? Yeah. And so a lot of times when I start doing presentations like FQHC, the intent is not to intimidate. It's not to kind of create such a high barrier of what I'm about to describe. It's more of just kind of an option. There will be other options that Muslim communities can do, but is an option for communities that want to actually build a community clinic. And there is like a formal program called the Federally Qualified Health Center. And it's not new. 45 years, the community clinic movement has been way in the forefront around all the buzzwords that you hear around health reform now, in terms of coordination of care, being a medical home, and so forth. Community health centers have been doing that for a very long time. The Federally Qualified Health Program is actually it's under the Section 330 Public Health Service Act, which is a specific part of allocated monies that can either fund 3 or 4 different programs. 1, community health centers. 2, actually migrant health centers, right? So clinics that actually follow the path of migrant health workers. There's also public housing grants. So actually community clinics can apply for federal grants and do it within major public housing programs. And then homeless grants as well, and also school-based health centers. So those are the kind of the main categories. And then there's something where you're not necessarily an FQHC, but you look like one. And I'll get into the distinction between that, because UMMA tried and failed close to 6 times in trying to get the FQHC. And we said, forget it, let's try to do the lookalike. Alhamdulillah, we got it, and then we became an FQHC. So I'll kind of describe that. They have to be private, charitable, tax-exempt organizations. They can join with public entities. In other words, FQHCs actually can join with local county departments or local public dish hospitals or publicly funded hospitals, and actually go in together as a co-applicant, so that is possible. But they are also they are mandatory to provide care for everyone, regardless of ability to pay. And so that will be a critical piece that I'll get into later on. Essential components is that it is community-based focus, and I'll get into the governance piece later on, but 51% of your board of directors actually have to be patients, consumers of your services. And they have to be specifically located in what the federal government or HRSA calls medically underserved areas, MUAs, or medically underserved provider shortage areas, or MUPs, right? So these are specific areas that, if you are considering a lot of times I get calls from different communities that actually want to start community clinics, but it just so happened, they say like, well, we want to open up a clinic next to the mosque, but the mosque itself is in a very affluent area. That's probably not the best place to start, especially if you want to eventually become an FQHC, because that particular neighborhood has to be already designated by the federal government that it is a medically underserved area. And if it isn't, you still can apply to make it and designate it one, but it actually is an involved process where you actually do a service area application where you essentially tell the federal government that this X census tracts and these zip codes and so forth justify your designation. But even then, that doesn't guarantee you getting the grant. You just designated just that neighborhood. So that's an important piece, especially if you're thinking about an FQHC, is to essentially look at your place or where you're at and whether it's a MUA or a MUP. The services that you provide have to be comprehensive. So it can't necessarily just be one particular area. So core, primary, preventive health, and I'll go into the required services later on, so I won't spend too much time there. Culturally and linguistically competent care. When UMMA first started, we had a lot of volunteers from undergrad volunteers that didn't necessarily speak the language of the community, and it obviously impacted the quality of care. And so a lot of times, like for example, we have now, alhamdulillah, 42 employees. Majority of them are from the community, which is an essential component. So it's important to make sure that your services are culturally and linguistically competent. And then the high quality care, it's not so much just because you're providing care to an underserved population should justify subpar care. You actually, the federal government holds you to certain standards that are held, and now even more so because of health reform, that are held, that hospitals are, you know, whether it be JCO or NCQA and so forth. So just every year, for example, UMMA has to submit to the federal government our healthcare plan, our business plan, and each have to be actually specifically delineated what our health outcomes are, what are the specific clinical priorities we want to achieve, whether they're both clinical as well as actually services that are necessary, for example, enabling services. Are there questions any so far, or we'll just keep that towards the end? Yeah, all right, let's go. All right, so the FQHC requirements. So you must demonstrate first via needs assessment why your application is worth sending to the federal government. And so you essentially have to do a full-blown needs assessment. You have to prove to the government, which is reviewed somewhere in Maryland, that on paper in a 200-page application, why your community needs another health center. And that tends to be very, very difficult. It's scored at a specific, you know, they score highly in the application's need, collaboration, your ability to actually translate the need to the services that you provide. So these are just a list of services that you have to provide above and beyond just having a doctor see patients. And that includes enabling services, whether it's transportation, translation services, being able to actually do case care coordination. Oftentimes, the uninsured, underserved populations do not have a specialist to go to, so you actually have, I mean, we have dedicated patient care navigators, and the fact that you have to title them patient care navigators kind of indicates how much of a difficult system it is, especially in LA County. You have to provide education above and beyond what happens in the exam room. So you provide education courses, preventive courses, and so forth. And then you don't have to necessarily provide in-house behavioral health, dental health, or substance abuse, but you have to have contractual relationships with community partners that can provide that information. But if the patient can't afford it, then you must require these contractors to do what is called a sliding fee schedule, or sliding based on ability to pay. So in other words, it's not just like, good luck patient, I know you have behavioral problems, and here's a referral slip. No, UMMA and that provider actually has to have a relationship, and then UMMA also has to pay that provider as well. So it's fairly involved in terms of the actual services that you provide. Staffing, you essentially can't have just a volunteer model. You actually have to have specifically you have to have bylaws that specifically say that your CEO is employed, your chief financial officer is employed, as well as your chief medical officer is employed. So those are 3 critical positions that actually have to be employed and actually have a formal relationship. And then we talked about the culturally and linguistic staff requirements there. So in the application, you actually, FQHCs have to develop what is called a QA or a QI plan. This is actually becoming even more of a focus after health reform, because obviously what's expected for all of providers come 214 is the importance of actually having plans that are outcome driven, right? So not only that, UMMA is expected by 214 to be able to share this data, not only these data with actually its board of directors, but also the county system as well as the state and so forth, because we are ultimately going to be assessed both by the federal government, the state and local, how well we're doing, and we'll be rated based according to our performance. You have to have accessible hours of operation. When UMMA first started, we were just open 2 half-days a week. That wouldn't have cut it if we wanted to become an FQHC. You have to provide services that make sense for the population, right? So if you're a migrant health center, opening 8 to 5, only one, and you're only stationary in one location and you don't move with your patients like migrant health centers do, then you won't be eligible. If most of your population can't come in during the day, but you have to be able to in the evening, and you have to make the case as well. Just for example, when we open up the school-based health center, we can't open it up only after school. We have to be able to provide the services during school hours as well. Hospital admitting privileges, making sure you have a continuum of care. And then ultimately, you have to be able to provide services regardless of the ability to pay. This is a very, very extremely important point, because a lot of our patients, prior to health reform, they were not poor enough, unfortunately, and according to the federal poverty designation, and we had to ask them to pay. But it's completely up to each health center how aggressive they're going to ask for collections. For example, UMMA, kind of just we say, here's what your charges are today, this is your sliding fee, and we kind of just, and surprisingly, a lot of our patients actually do make it a point to pay. But there's another extreme where other health centers in the country actually send their patients to collections and so forth. So it takes a whole diverse mix. Program requirements, so here's probably the most difficult barrier that UMMA experienced was the governance requirement. When the board found out that when I was sharing with them one of the requirements, they're kind of just saying, okay, that makes sense, we want to be a better institution and so forth. Oh, you want the majority of the board, which at the time were founders, to essentially be ineligible to serve on the board, because we had the majority at the time were physicians, and the rule is 51% of your board cannot be physicians, right? And then the 49%, the majority of that 49% cannot receive more than 10% of their income from the healthcare industry. So it's not only just physicians, it could be a healthcare consultant, it could be a person who is business law, but he or she works in healthcare and so forth. So essentially, and this is what a lot of respect that I have for the founders, they gracefully stepped off, they had the big picture in mind, and they bit the bullet and said, you know what, let's make this board eligible. So it's essentially, that's probably the biggest barrier for FQHCs, because they truly, and they really mean business in terms of making sure that this particular requirement fits the operational mode of the clinic. So what are the benefits? Why go through all of this? There are a lot. You have access to federal grants up to a maximum of $600,000 a year, and they are somewhat renewable. You compete every 5 years, but essentially a $600,000 grant to offset your uncompensated care is a pretty good deal. You also get enhanced PPS rates. So most docs, the reason why Medicaid populations are poorly served by private physicians is because the Medicaid rate is poor. And in California, it hasn't changed since the 80s. But as an FQHC, you actually get an enhanced rate that's based on cost. And it's fairly technical, I won't get into that. But it's actually a very good thing. for right now, because that will also change in health reform. Discount drug pricing, you know, we all know pharmacy costs can be significant. The federal government will cover for FQHCs, your malpractice. The U.S. Attorney's Office would actually defend you if you have a malpractice case. So that's pretty significant. Access to vaccines. You become a site that you can attract physicians and pay for their student loans through the National Health Service Corps, and also the fact that FQHCs were written in as a core backbone of the Affordable Care Act. So in other words, the health reform was essentially built around the successful models of community health centers. So in terms of sustainability, that's a good position you want to be in. Now, specifically, the lookalikes are essentially very simple. A lookalike is you have to comply with all FQHC rules, but you don't get the grant. It is difficult to kind of do all that, but there are benefits to that anyways. You do get the enhanced rate. You have to make sure that you're still in those underserved populations and so forth. So as I close, there is significant, and some are already expended, monies from the Affordable Care Act, where essentially $11 billion over the 5 years. Some have been actually already expended, like $1.5 billion in the capital, you know, to actually build new clinics. That pot is gone. Expansion 9.5, that 9.5 billion is still being debated in any of the debt ceiling discussions we've had recently. So some of that money's been extracted, but by and large, the money that around the health reform act actually built in the infrastructure of supporting new health centers. And so that is something to consider in terms of where the healthcare system is going and the investment. Opportunities to become an FQHC, from the perspective of a health center that we were a free clinic and we were a community clinic, you're best positioned to serve the newly uninsured. There are definitely growth opportunities. These whole concepts of the triple aim, you know, based on cost, quality, and patient outcomes. Free clinics and community clinics have been doing that forever, especially care coordination, patient-centered medical homes. All these things are now kind of in the works that we've been working on for the past 2 decades. So there's definitely opportunities for FQHCs to actually leverage that experience. The challenges, of course, is that community health centers will no longer be the provider of last resort. In other words, we shouldn't visualize ourselves as one anymore. Yes, we still will be serving the uninsured, predominantly the undocumented, but we have to change our model of actually building up our capacity to do customer service, to retain patients, because there's going to be a lot of new players coming in to serve the Medicaid population, and so FQHCs have to be able to serve that population. There is uncertainty with how we will be paid, but that gets in a whole other, in the next 2 years, that's where the FQHCs are going to be fighting as to the best, you know, how do you maintain how we were paid before, and how does that fit into the new models of payment and reform? And the only last point is the Supreme Court decision now made all, you know, Medicaid populations, or potentially the delivery of services to Medicaid populations, very different in different regions. And so some FQHCs in some states, if you're in a state that chooses not to truly commit itself to health reform obligations, then a lot of those FQHCs are caught holding the bag of providing uncompensated care on their own without any state-supported programs. Sorry, I had to rush through all of that, inshallah, in respect for all of everybody's time. But inshallah, if there are questions and answers, or you wanted to wait till...
No, you have to
Yes, yes. So if there are... It's a lot to process, but if there are a lot of... Any questions or... Yes?
Are you guys thinking of in future, say, franchising UMMA clinic? Or another question I have is, do you have a list of resources available, like grant writers or other resources in case somebody is pursuing the course of FQHC? And also that, what's the initial cost of running, like before you get FQHC, like running FQHC lookalike, the initial cost and also like running costs for you?
Okay. first question around the franchising, we get that a lot. It tends to be very difficult to actually franchise to get scale, if you will, as opposed to like maybe a hospital chains that actually can gain scale in terms of moving and having a system to actually open up clinics within different regulatory environments. As you know, or everybody knows, LA is very local in terms of different, from county to county, state to state could be very different. So I haven't seen too many FQHCs actually cross state lines. Some have actually crossed Orange County lines, but we haven't really considered that as a long-term right now. But that can be definitely in the future to at least move maybe in different counties. For resources, there are a lot of resources. The National Association of Community Health Centers has an extensive resource for FQHCs or people who want to open one. I often can ask people to look up and Google the title, "So You Want to Start a Health Center?" And it's a 600-page document. Don't get afraid of that. Just look at to get an idea. The table of contents can kind of give you an idea of like the frame of what it takes in terms of infrastructure, which kind of leads to your third question, which is what are potentially the costs? Well, you can become a FQHC lookalike, but there are certain infrastructure items that require a budget, like, for example, the level of management, the ability of, for example, you have to have a clinical lead, a CEO, you have to have a financial, so the overhead can be significant if, especially, you have to also ensure that you have billing and you actually get third-party payers. So our budget when we became an FQHC lookalike was $2 million at the time, actually 1.5 million at the time. So it was still relatively, we only had one doctor at the time. So now with next year we'll be at five physicians, inshallah. And so it varies in terms of budget. Yes?
I have a question about physicians and healthcare providers. In the past, as like free clinic, you get volunteer physicians. Now you get like staff physicians. How do you deal like with volunteer physicians? Do they have to use their privilege with the hospital for a physician, or do they have to use the clinic as a platform?
Yeah, traditionally UMMA has been, we started off as a volunteer model, but over the years we shifted to predominantly, rather than having a physicians providing primary care, a lot of our physicians now are specialists, which is extremely helpful. And so they essentially, we cover their malpractice, and they, for all intents and purposes, don't need to admit, even though we are required for our own physicians to admit. So the requirements for volunteers, usually the biggest question, and I'm sure in the respective communities and my panelists as well, is who pays for the malpractice. That usually is the biggest barrier, but alhamdulillah, UMMA hasn't had that problem because we actually cover their malpractice and have tail coverage as well for them.